Hi class, my name is Tori Larson. I spent my time in this class searching for the best available evidence in reducing arthritis pain. I was looking for an intervention related to lifestyle modification. Obesity and osteoarthritis often affect people simultaneously. 1 in 2 adults in the United States are overweight, cited from Must et al. In the year of 1999. Barbour et al. In the year of 2017 found a 15% increase in obesity prevalence for older adults diagnosed with osteoarthritis from the years 2009 to 2014. Osteoarthritis can cause pain, can decrease functionality, and decrease health-related quality of life. Osteoarthritis can even prevent people from completing their activities of daily living. Osteoarthritis is a preventable disease. Cited from Lee in 2015, osteoarthritis costs are greater than $18 million annually per 100,000 persons. My PICO question that I proposed is, in overweight or obese adults with osteoarthritis, what is the effectiveness of non-pharmacological and non-surgical interventions in comparison with no treatment or standard treatment? And this would be on the improvement in osteoarthritis pain. The population chosen is overweight or obese adults over the age of 18 who have osteoarthritis or are at high risk for osteoarthritis. The intervention is to be non-pharmacological and non-surgical, including lifestyle modifications. The comparison is no treatment or standard treatment, which is considered therapeutic exercise. The outcome is measured by improvement in osteoarthritis pain, decreased knee compressive forces, and decreased interleukin-6 levels, improved functionality, improved mobility, and improved health-related quality of life. Intervention groups that were found in the best available evidence articles included education on self-management for the treatment of osteoarthritis, land-based therapeutic exercise in the treatment of osteoarthritis, diet modifications or diet modifications with therapeutic exercise in the treatment of osteoarthritis. Control groups that were found in the best available evidence articles included minimal education on self-management in the treatment of osteoarthritis, non-exercise and non-treatment, and then standard treatment, which is an exercise-only control group. Primary and secondary outcomes that were found in the best available evidence articles included functionality, improved functionality, decreased pain level, improved health-related quality of life measures and these were outcomes that were measured in all 3 articles. The randomized clinical trial that was found also measured knee compressive forces, interleukin-6 levels, and mobility. After completing an exhaustive search of 4 databases, 2 systematic reviews were found, and 1 randomized clinical trial was found. The systematic review was, one of the systematic reviews was of randomized controlled trials and other study designs, so that was ranked a 1B on the JBI levels of evidence hierarchy. The other systematic review was of randomized controlled trials and was ranked a 1A on the JBI levels of evidence hierarchy. The randomized controlled trial was ranked a 1A on the JBI levels of evidence hierarchy. The first systematic review that I'll go over was I found the effectiveness of self-management educational interventions for osteoarthritis of the knee by Smith et al. In 2009. While searching for evidence, I found the title of this article seemed very pertinent to the subject of interest. After reading the abstract, it was determined that it was a systematic review, and it was a level 1B. The search strategy for this review was very thorough and was key to its success. They used appropriate keywords, truncation, and Boolean operators. They searched 22 databases, completed a hand search of reference lists, and searched postgraduate and doctoral dissertations. After finding pertinent articles, the JBI critical appraisal tool was used by these review authors. All reviews of articles and their data was completed by 2 independent reviewers. Through the review, they found that exercise training is beneficial in managing pain with knee osteoarthritis. Weaknesses that were found in this study was that there was a lack of adequate blinding. They also deemed their methodological quality as moderate. And the reviewers stated that the small sample size may have caused a type 2 error. It is also stated in here that the trials did not always explicitly explain the method of randomization or the descriptions of the control groups. The second systematic review that I found was on Joanna Briggs. The first one was on Cochrane Library. Exercise for osteoarthritis of the knee, Franson et al., 2015. The article's title, again, seemed very pertinent to the subject in question. After reading through the abstract, I found it to be a systematic review of randomized controlled trials, a level 1A on the JBI levels of evidence. The review utilized a strong search strategy by using appropriate keywords, truncation, and Boolean operators. 5 electronic databases were searched, along with gray literature and hand searches of included studies references lists. Articles were reviewed for quality by GradePro. Article data was extracted and bias was assessed by 3 teams of 2 review authors. It is very clear that all data from the included studies was carefully evaluated in the review process. It was found that there is high quality evidence showing that land-based therapeutic exercise reduces knee pain and improves quality of life. There is moderate evidence that functionality improves with exercise. Weaknesses of this review include possible publication bias because 2 articles they were unable to find full text on. They limited the articles to English language. And it is stating that no treatment control groups and blinding not being performed may have caused the research to miss the placebo effects and to rule that out in some studies. Many of these studies evaluated persons with mild osteoarthritis, which does not show a good sample of other levels of osteoarthritis. And then when participants had mild osteoarthritis, it was difficult for them to report on their pain levels from day to day because they did not persistently deal with the side effects of the disease process. The third article that I chose was a randomized clinical trial called The Effects of Intensive Diet and Exercise on Knee Joint Loads, Inflammation, and Clinical Outcomes Among Overweight and Obese Adults with Knee Osteoarthritis, the IDEA randomized clinical trial by Messier et al. In 2013. During a hand search, I found this article. It was quickly noted that it was a randomized clinical trial and was level 1A evidence on the JBI levels of evidence hierarchy. This trial is strong due to the fact that it runs over 18 months. It has a fairly large participants in the study at 454. And then the criteria for participant inclusion is of high quality. Not only does a participant have to be diagnosed with knee osteoarthritis, but they must also have pain and radiographic evidence of knee osteoarthritis. Other criteria included for participants was for them to meet the criteria that they are obese, ambulatory, community-dwelling adults 55 years or older with a BMI of 27 to 41. What is most appreciated with this trial is they have a way to measure improvement objectively. They measure with a primary outcome of knee joint compressive forces and interleukin-6 levels. And then secondary outcomes measure pain level, functionality, mobility, and health-related quality of life. It was found that the participants who were placed in a diet modification group had weight loss and had a reduction in interleukin-6 levels and decreased knee compressive forces. When participants were placed in a diet modification and exercise group, they had weight loss, a reduction in interleukin-6 levels, and improved health-related quality of life. A weakness of this study may be that they had an 88% completion rate, but they did state that this was a good value when compared to similar studies. The study has weaknesses, one of them being a focus on mild to moderate osteoarthritis, not being able to define if these interventions would work for severe osteoarthritis. The measurement of knee compressive forces has limitations, but they explained that it has been in agreement with other similar measurement models. And then lastly, the study was done at a single site compared to a multi-site trial where they would have had a larger number of participants. So as stated, the two systematic reviews completed exhaustive searches that were very thorough. They also had a very thorough review and appraisal of the articles that were compiled for the systematic reviews. One systematic review was from JBI and the other was from Cochrane Library. Both of these are fabulous databases. The randomized clinical trial was a single-blind study. They did not describe the randomization well, but they did a long-term follow-up at 18 months. And then they also brought a new way to objectively measure their primary outcomes with the knee compressive forces and the interleukin-6 levels. All the studies had a common consensus that exercise decreased pain levels, improved functionality, and improved health-related quality of life. There were no severe adverse effects from this intervention. Patient experience was taken into account by measuring health-related quality of life across all articles. This recommendation of exercise in the treatment of reducing arthritis pain was given a JBI grade A recommendation. Implications for the advanced practice nurse include prescribing diet modifications to coincide with therapeutic exercise in the treatment of osteoarthritis. Another intervention that was shown to be successful in the JBI systematic review is education on self-management about therapeutic exercise in the treatment of osteoarthritis. Implications for further research includes a recommendation for larger sample sizes, improved blinding, and improved descriptions of control groups. A treatment control group is recommended to rather have a treatment control group rather than a non-treatment control group, so that it's easier to rule out a placebo effect. Lastly, there is a need for better descriptions of how the studies randomize their participants, more thorough description. This would be extremely helpful in judging the evidence. And then my question to you is if osteoarthritis is preventable, and if so, what are the best interventions that advanced practice nurses can implement for the prevention and treatment of osteoarthritis? That is a lifestyle modification. And how do you see yourself doing so? Thanks for your time.